Hey everybody, welcome to our third and final presentation in our series on emergency department ventilator management. In this presentation, which is going to be our probably briefest and probably simplest as well, we're just going to discuss troubleshooting of a few common ventilator alarms. I find ventilator alarms kind of unsettling. The fact that something is wrong with the system that a patient is depending on for their breathing is worrying. And I don't know about you, but I've had several moments either in the ED or in an ICU when a ventilator alarms and I wasn't sure what to do. They have lots of alarms, and this presentation can't possibly cover all of them, but there are a few common or critically important alarms which are pretty easy to understand, and that's what we'll cover. So I hope that after this session, the next time you hear a ventilator alarm, you'll feel prepared to help troubleshoot it rather than pretending not to hear it and hoping somebody else shows up. I've been there. So our objective for this session is just this one. So we're going to identify causes for and troubleshoot high pressure, low pressure, and low minute ventilation alarms. And we'll start with high pressure alarm. So in my experience, this is probably the most common alarm going off on a ventilator. And the process is pretty straightforward and starts with checking a plateau pressure. So it's helpful to have a simplified idea of what peak and plateau pressures each represent. It's more complicated than this, but an easy way to think about it is that a peak pressure is an indicator of airway resistance, and a plateau pressure is an indicator of lung compliance. You will commonly run into situations where both peak and plateau pressures are elevated, or maybe you'll have a high peak pressure and a normal plateau pressure, and this will help you distinguish some of the various causes. So first, we're going to talk about the situation where you have a high peak and a normal plateau pressure. So like we said earlier, peak pressure can be thought of as an indicator of airway resistance. In this case, the patient's airway is contiguous with the ventilator circuit. So increased resistance could be coming anywhere from the ventilator all the way to the patient's bronchioles. A careful examination from the ventilator all the way to the patient's lungs is needed. A good first step is to check ventilator tubing to look for kinks. This can be an easy fix. If you notice some kink tubing and unkink it, you very well may resolve the alarm. If the tubing is okay, your problem then may be with the endotracheal tube or with the patient. So check the size of your endotracheal tube. This is a significant factor in airway resistance. If you have a patient intubated with a small ET tube, this could easily be your source, and you could consider exchanging for a larger diameter tube. If your tube size is adequate, you could still have secretions which are narrowing the diameter, or potentially the patient is biting the tube. Both of these effectively reduce the diameter and increase resistance. And kind of like we think about for IV gauge and length for like trauma resuscitations with blood, the radius of an ET tube is taken to the fourth power when factored into flow rates. So you can understand how even just a very small change in the diameter of the tube can make a really significant effect on the resistance and the ease of which the ventilator can provide breaths to the patient. If you have a situation where there's secretions or you have the patient biting the tube, you can attempt passing a suction catheter through the tube, see if you can get some of those secretions out. You could also add in a bite block. If you have examined the ventilator and now the tube and not identified a cause, perhaps the problem lies with the patient's lungs, and bronchospasm could be a common cause here. Take a listen to their lungs. If you hear wheezing or diminished breath sounds, go ahead and try a breathing treatment. It very well could improve your peak pressures, and there's generally pretty little downside to it. The next situation we'll talk about is when both the peak and plateau pressures are elevated. And this scenario suggests decreased lung compliance. Has the patient been getting progressively harder to oxygenate? They could be developing a worsening of an existing pneumonia or pulmonary edema, or perhaps they're developing a new condition like a ventilator-associated pneumonia, for example. You can use the rest of their clinical picture to help you figure out what is going on here. So if they've been developing leukocytosis and fever and their chest x-ray is showing a new consolidation, perhaps it's pneumonia. If you've been giving lots of fluid resuscitation and now you're seeing peripheral edema, perhaps there's pulmonary edema as well. And here you want to kind of use your exam to guide uh, your attempts to resolve this alarm and the elevated pressures. Another couple of causes can be main stem intubation or pneumothorax, and this will cause elevated pressures because you're essentially trying to ventilate one lung with the volume intended for two. So take a listen to your patient's lungs, consider getting a chest x-ray. Some of these situations, like say main stem intubation, may be very easily correctable. Others, like worsening compliance from pneumonia, this may require adjustment to your ventilator strategy. Maybe you need to go for something that focuses more on a lung protective strategy, kind of like ARDS, or just treating of the underlying condition. And there may not be a particularly quick fix for it. The next alarm we'll talk about is a low pressure alarm. And so this is pretty simple to think about, but it's perhaps more urgent than the high pressure alarms. So when a low pressure alarm goes off, there's a couple life-threatening causes that should quickly be checked. So one is circuit disconnection. So follow the ventilator tubing from the ventilator all the way to the patient. It's easy to understand how if that tubing comes undone, the ventilator is not going to be detecting much pressure at all, and this alarm is going to go off. And that could potentially be a fatal cause if this patient is depending on that for their respirations. If nothing is disconnected, another good cause to check for is a cuff leak or a herniated um, cuff. So cuff leaks can be caused by either a defective or a torn cuff. Um, and then a pilot balloon defect could cause this, and then a cuff that is herniated above the vocal cords. In all these situations, the cuff is no longer sealing with the trachea, and you're going to have air escaping around the cuff, and as a result, lower pressures. And this could potentially be a dangerous thing too, because you're no longer ventilating the patient as intended. Some of the ventilators will be able to detect a cuff leak for you. If you don't know how to do this, you can take a listen to the patient's neck, check the pilot balloon. You could always consider taking a look with a laryngoscope in the patient's mouth and make sure that the tube is through the cords, or if you wanted to do a bronch as well, that would work. If the cuff is above the cords, obviously you're going to want to advance the tube, and if the cuff is torn or faulty, that's just going to need an exchanged tube. The next alarm that we'll talk about is low minute ventilation. And this alarm triggers when the ventilator is detecting less air returning to the circuit than it is providing. And there are really only a handful of causes for this, and some of them are very similar to the low pressure alarm. So a cuff leak can trigger this. In the cuff leak, just like in the previous example, air is escaping around the ET tube rather than being forced to return through the tube. So this can trigger the alarm. The same thing is again true when an ET tube is placed with the cuff above the vocal cords and it cannot seal with the trachea. Again, we want to either reposition or replace the tube in these situations. And then another less common but important cause of low minute ventilation is a bronchopleural leak. And this could be a patient with a chest tube or maybe a bronchopleural fistula where air is escaping through the defect or through the chest tube rather than returning to the ventilator and triggering the alarm. And this is a bit of a less intervenable cause, but nevertheless, it would be important to know, and at least you would have a reason for your alarm. Those are really the key alarms that I wanted to cover here. There are certainly more, and some of these references that I have listed here go deeper into it and are worth taking a look. I hope that the next time a ventilator alarms and you're around, you feel more prepared to tackle it. You have more knowledge about this and more capability than you think. And this presentation will also conclude our series on emergency department ventilator management. Mechanical ventilators can certainly be complicated and somewhat scary machines to work with, particularly when you have a patient whose life is depending on it. But although that is the case, it's well within our scope and abilities to manage a ventilator, and that is really with or without a respiratory therapist. I hope that this series has given you a foundation or built upon the knowledge that you already have. So thanks for joining me and appreciate your attention.